mechanical ventilation.
Thanks so much, Massimo. Good morning, everybody. This is a difficult issue, and even more discussing this shortly, but unfortunately we ran out of time, so I'll try to stick to the important points which, in my opinion, you need to take into account when you wean patients from the machine after applying all the knowledge that you have heard before, settings in the ventilator, withdrawing the assistance in COPD patients or other kinds of individuals. And when you go to the weaning period, you have to perform an overall clinical assessment of these patients. You need to take into account the breathing pattern and the control of breathing. You need to know more or less the respiratory system mechanics, which in turns means how much work, how much energy the patient will need to breathe by his own or her own. You'll need, of course, as you have heard before, to have an appropriate, perhaps not normal, but an appropriate gas exchange. And you have to estimate the cardiovascular performance, because after all, starting weaning and disconnecting the patient from the machine means a sort of exercise. So you have to be in relatively good shape from that point of view. And of course, the last point of the weaning process is to extubate the trachea. And here another critical issue is not to know whether or not the patient will clear the secretions and protect his or her upper airways. This is data published this year in the Blue Journal. This is a multi-center worldwide study that perhaps some of you participated. And what I want to show you here in this busy slide is that the majority of patients that go through the weaning process, the vast majority of them do it successfully, and only about 1/3 of them fail the first attempt to wean. And this first attempt to wean is usually done with a spontaneous breathing trial. Okay. So this is the idea that we have when we wean patients from mechanical ventilation. This is the whole process of ventilation from the beginning, so intubation of the trachea, till the end, extubation of the trachea. And here you have very early in the course of the disease, the patients probably are ventilated, probably deeply sedated, ventilated with, say, quite high settings of FiO2s, PIBs, etc., whether you are not thinking on withdrawing the support. So no one of us will think of withdrawing the machine when the patient is at 80% oxygen and PIB of 12. So we will think about withdrawing the assistance once the patient began to stabilize, right? And this is what is called the screening process, right? So for the screening process, you need to use a test that tells you that this patient has a relatively high likelihood of breathing spontaneously without the tube, all right? And this is why we use the predictors. And then, because we are not sure that this patient will tolerate a spontaneous breathing indefinitely, we let the patients to breathe by their own, usually for a maximum of 2 hours, and if the clinical tolerance to this spontaneous breathing period is or low assistance is correct, then you perform the extubation, knowing that the extubation in a relatively small percentage of cases will fail. There is in all the reports the extubation failure rate is about 15%. It depends on specific populations, but overall is about 15%. And if the first attempt to wean, the patient is intolerant to it, then you may choose to a progressive withdrawal of mechanical ventilation, nowadays often with pressure support ventilation, and you progressively withdraw the levels of support until these are very low, and you proceed again to extubation. And of course, here there is, in the peri-extubation period, even before, but to tell you the truth, the data is not consistent yet, but after the extubation, there is a role for the use of non-invasive ventilation to avoid the reintubation. So, is this important that after you have screened your patient, and the main screening tool is, as I told you before, is disconnect the patient and to look at the ratio of frequency of over tidal volume. This is the Young-Tobin index and has been described below 105. And when this index is below that value, there is a very high likelihood of the patients being tolerant to a spontaneous breathing and being extubated. But some other patients do not tolerate. And during this period of 2 hours, and indeed this confirmation period of 2 hours is important, because if you do not confirm this first skinning test, the F over BT, then you look here in this study, the authors had patients that had all criteria, all clinical criteria for being extubated. They had a ratio of F over BT below 100, but they didn't wait for 2 hours time, were rapidly extubated. And as you can see here, the extubation rate is extremely high, about 40%. So it's important to wait for at least between 30 minutes and 2 hours before taking the decision to extubate. This is data comparing these two different durations, 30 minutes and 2 hours. And as you can see here, the outcomes for both reintubation and successful extubation were identical, and thus you can choose between these two ranges according to the particular characteristics of the patients. Another issue is whether or not the TPs and low levels of pressure support are clinically similar from the point of view of tolerance and outcomes. And again, here in this study, the authors compare this weaning trial during a total unassisted breathing, which is the TPs, and giving very low assistance with a pressure support level of 7 centimeters of water. And again, in this study, you can see that the reintubation rate is identical using either the TPs or the low level of pressure support. And the successfully extubated patients, 48 hours after the extubation, as you can see here, is virtually identical when you use the TPs or low levels of pressure support. So it looks like from a clinical point of view, these two Weaning trials can be considered as very, very similar. So when we follow this strict methodology of screening patients quite early in the course of the disease and letting them to breathe spontaneously, we see that the vast majority of them, about 70%, will be extubated at the first attempt. So they are relatively easy patients to wean from the ventilator, but there is still a percentage of about 30% of subjects that won't tolerate this first attempt of withdrawal, because they often exhibit this pattern of rapid and shallow breathing. When you disconnect them, the patients breathe very rapidly with very tiny tidal volumes, and this is often accompanied with hypercapnia if you leave the patients to breathe for a prolonged period of time. And this happens essentially because the patients who will go on to fail, they exhibit marked changes in the respiratory system mechanic characteristics. These patients who will intolerate the weaning attempts when we disconnect them from the ventilator and exhibit this rapid and shallow breathing pattern, they usually exhibit marked increases in the amount of intrinsic PEEP, which is an increased elastic load. They exhibit also an increase in elastance, so a decrease in compliance, probably because they are hyperinflated. And also they exhibit an increase in airway resistance. All right? So they have an extremely high workload to counterbalance, because the elastic load is increased and the resistive load is also increased. So this huge load, these patients cannot be able to counterbalance with his or her respiratory muscle effort, and they exhibit this typical rapid and shallow breathing pattern. So in these subjects, one can choose to reconnect them to the ventilator and wean them with progressive withdrawals of pressure support, or an alternative is to again use volume assist control ventilation and restart the spontaneous breathing trials at least once per day. What is not recommended at all, and all these studies are very consistent on this, is to use not the synchronized intermittent mandatory ventilation. This is the worst way to wean patients from mechanical ventilation, and it is not recommended as a weaning method. Actually, nowadays, as you can see here, as long as the time course of mechanical ventilation goes on here on the horizontal axis, from the beginning of the ventilation till the end, here to your right, you can see that the use of pressure support ventilation, which is very low in the very beginning for obvious reasons. In the very beginning of mechanical ventilation, still the most commonly used mode is a surge control ventilation. As long as the times goes by, there is a progressive increase in the use of pressure support, probably with the purpose of withdrawing the ventilatory assistance as soon as possible. One issue with the withdrawal of mechanical ventilation with pressure support is its automatization. You know that there are systems that according to the breathing pattern of the patients, the respiratory rate, the tidal volume, the end-tidal CO2 fraction. The machine takes decisions not in order to increase or decrease automatically the levels of support, with the idea of hastening or shortening this period of withdrawal. This is the pivotal study comparing the usual weaning with this automated weaning method. And in this study, what it was observed was that the automated weaning method gave as a result a significantly shorter duration of ventilation as compared to the usual weaning with the progressive decrease of pressure support, as it was done clinically in the participating centers. These data, however, were not confirmed in this other study, a study which included a lower number of patients, and in which the caregivers were taking decisions permanently to accelerate the weaning process. No, this study was done in a center with a very high ratio of nurse to patient, so they had time to to control and to accelerate for weaning in a quite safe way. And also the population here is different as compared to the previous one. And here, as you can see, there are no differences between the best possible usual care and this automatic weaning system. Again, this is, as far as I know, the more recent data using these methods in surgical patients. And again, overall in these 300 patients, there were not significant differences, but it was a significant difference in the subgroup of patients submitted to cardiac surgery. So the message of all this is that automatic methods at least perform as well as usual weaning perform by experts in very good clinical conditions. An important issue that I want to comment regarding weaning, and in particular patients with difficult weaning or even prolonged weaning, in other words, patients who did not succeed the first attempt to being weaned from the machine, is the issue regarding the cardiac failure. No, as I told you before, the study by Gibran and Tobin showed significant increases in resistance in patients who went on to file spontaneous breathing trials. Okay, so we know you have seen that these patients increased the levels of orapip here, and increased the levels of elastance. So they increased the elastic load, but as you can see here, they increased the resistive load. And it is not clear why such a huge increase in resistance happens. And of course, one possibility, especially regarding the COPD patients, is that this is not due to the lung, but perhaps to the heart. And we do know that during a spontaneous breathing trial, in the sudden switch from positive pressure ventilation to a spontaneous breathing with negative intrathoracic pressure, there is an increase in venous return. There is an increase in the left ventricular afterload because the blood pressures are quite negative, so there is a high transmural pressure in the left ventricle. And because this is exercise, it increases the myocardial oxygen demand. So you have to be careful in patients who have a clinical a clinical history of coronary artery disease. And also there is the hyperinflation due to the intrinsic PEEP. This can generate a morphologic restriction in the left ventricle, thus reducing left ventricular compliance and giving what happens?
I don't know. But there is no slide on the screen. Okay.
Sorry. And this may lead to left ventricular failure with pulmonary edema that may alter the weaning process. Actually, no, this has been shown nicely in this old study by J Mancebo in COPD patients, in which here you can see how these patients are breathing during positive pressure ventilation. And this is the pulmonary capillary wedge pressure here, which is normal, and the inspiratory effort. This is a spontaneous breathing, 5 minutes, when the patients started to intolerate the spontaneous breathing trial. So you see that the respiratory rate is high and the effort is enormous. Here, this is the esophageal pressure swing. And look how the pulmonary capillary wedge pressure increased until it's well above 14 centimeters of water, indicating the presence of pulmonary edema. And here you can see how the effort is decreasing, perhaps indicating a very initial stage of respiratory muscle fatigue. So this is a real issue in these patients. And also in patients difficult to wean, and here in this study, many of whom had COPD and many others had a reason, a cardiovascular reason for starting mechanical ventilation. What we saw is that the tolerance to the TPIS trials was 0%, whereas the addition of pressure support with or without PEEP changed profoundly the tolerance to these spontaneous, to these breathing trials. So you need to be very careful when evaluating patients with pressure support according to his or her tolerance, especially if they are patients with a clinical suspicion of left ventricular failure. Actually, here half of the patients again increased the pulmonary capillary wedge pressure above 18 millimeters of mercury during the TPIS trial, indicating impeding early acute pulmonary edema. Again, this is data by Brook and co-workers in a large series of COPD patients ventilated invasively or non-invasively. And again, here you can see that with the help of biomarkers, BMP and proBNP, you can see that close to 50% of the patients with COPD have also left ventricular dysfunction, which when they go to the weaning period, this can be a source of intolerance. This is a study using these cardiac biomarkers, in particular BMP, to drive weaning and to manage fluids with diuretics in order to try to hasten the process of weaning. And here you can see that patients in whom the weaning and the diuretic strategy was driven with these biomarkers, these patients had a significantly higher extubation as compared to the patients treated conventionally. It's interesting to note, however, that the time to the first extubation to the successful extubation and the total weaning time. These favorable differences were mainly driven in those patients in whom a left ventricular dysfunction had been diagnosed. So this is an important piece of clinical information that you need to evaluate when you wean patients from mechanical ventilation and take into account the possibility that weaning can be impeded because of an untreated or non-suspected left ventricular dysfunction. Another issue with weaning, of course, is the management of sedation. Often, at least in the very beginning of the intubation and mechanical ventilation, patients are sedated, perhaps deeply sedated, and we do know that policies for sedation are highly variable from one institution to another, and this data came from Chicago, in whom the authors tested to a strategy. Patients that were submitted, one group was treated according to the usual sedation strategy, which was a progressive withdrawal of sedatives, and other group of patients was treated with sudden suspensions of the sedative. So the sedatives every day were completely stopped, and these two groups were compared. And very interestingly, the patients in whom the sedatives were suddenly stopped, these patients exhibited a significantly less ICU stay and less duration of mechanical ventilation. And it's also interesting to note that these patients in whom the sedation was abruptly withdrawn, these patients, because probably they were evaluated neurologically without the sedatives, they needed less radiologic diagnostic tests in comparison to the others. For patients with very difficult and prolonged weaning, perhaps no other active strategies are interesting, and one is early physical activity. This is again data from this center in whom they have a lot of experience in managing this process of weaning. And here the patients were, the group of patients submitted to an early rehabilitation strategy. These patients had a much better functional status, and they recovered a normal functional status much more rapidly than the patients treated usually. Of course, mobilizing patients with still intubated and mechanically ventilated is challenging. You'll need probably a bunch of motivated caregivers and nurses. But if you have enough personnel and you have the right skills, this is doable and is probably useful in some subjects. Well, we have seen that I told you before that when patients pass the weaning trial and they tolerate the spontaneous breathing either at the first attempt or the subsequent attempts, there is a risk for the extubation failure. And then perhaps there is a role for non-invasive ventilation. This is one of the first studies that tested the use of non-invasive ventilation in comparison to usual care in patients exhibiting post-extubation acute respiratory failure patients. And this study was stopped early because it was a trend for an increased mortality in patients treated non-invasively. However, there were patients that were crossed over, that were in the standard Weaning group, that were also treated with non-invasive ventilation, and these patients paradoxically did quite well. They had a complete reverse trend in comparison with the patients that received initially non-invasive ventilation, which make us to suspect that patients that were crossed over to non-invasive ventilation were selected patients that were treated in specialized hospitals with high knowledge on the technique of non-invasive ventilation, and this data confirms this suspicion. This is data by NAB and co-workers, only 3 centers, all experts in performing non-invasive ventilation, and using it in the patients at risk. And at risk is patients hypercapnic, congestive heart failure, and patients difficult to wean, who failed at least one spontaneous breathing trial. And in these subjects, the use of non-invasive ventilation to avoid reintubation, as you can see here, was highly successful. Again, this data has been confirmed in centers having experience in the use of non-invasive ventilation here in clinic in Barcelona again. And as you can see here, the major benefit of using non-invasive ventilation is in patients who are hypercapnic. So in patients that you extubate and are at risk, you have to take into account that hypercapnia is a major risk, and these patients may benefit from non-invasive ventilation. And then here, the same group confirms this data in using non-invasive ventilation as a rescue therapy. This is the use of non-invasive ventilation, and I'm finishing with this, as a tool to shorten the period of mechanical ventilation. This has been used in COPD patients. This is the initial positive report by NAB and co-workers that has been partially confirmed in this other selected study by Ferrer and co-workers, in whom, again, the use of non-invasive ventilation in very, very, very selected patients in comparison with the usual withdrawal of the machine may help in the decrease the duration of mechanical ventilation. This data, however, has not been confirmed in this other multicenter trial conducted in COPD patients, in whom the authors tested 3 strategies: the usual weaning, the administration of oxygen by mask, and then rescue therapy of non-invasive ventilation, and the use of non-invasive ventilation. And you can see here that the reintubation rate was, which is the main endpoint of the study, was roughly the same according to these three strategies. So just to conclude, I think that the time course of weaning in general in the vast majority of patients is quite predictable, and this is based on a quite simple screening strategy that has to be made relatively early in the course of the disease. In difficult to wean patients and patients exhibiting a prolonged duration of mechanical ventilation, here you need to take into account many more issues such as the managing of sedation, nutrition, cardiac failure, etc., because this will likely affect the whole duration of ventilation. Weaning, as you have seen, is not totally a risk-free process, because still some patients will need reintubation, and those reintubated patients have a relatively high mortality rate of about 30%, the same as if they were beginning mechanical ventilation. And non-invasive ventilation is in selected subjects useful to avoid post-extubation respiratory failure and to avoid reintubation, and data is still inconsistent to recommend it as a systematic weaning tool. Thank you very much.
Thank you, Jordi, for this very comprehensive presentation touching